The following podcast is part of a certified educational activity titled Nursing Strategies in Transthyretin Cardiac Amyloidosis, Targeted Therapies and the Patient Experience. Access the entire activity and complete the post-test at peerview.com/HXH860. Downloadable slides and practice aids are also available.
Hello, everyone. Thank you so much for joining on this Friday Eve. I realize it's the tail end of your day, and what is between you and food is our presentation. So thank you so much for being here today. My name is Dr. Lauren Edgar, and it is truly an honor to be a part of tonight's panel, especially on the topic that impacts so many patients and often goes unrecognized for too long: transthyretin amyloidosis. Tonight's panelists include myself, as well as Dr. Felker and Dr. Bott. And tonight is not just about understanding this complex condition, but about equipping ourselves, especially as nurses, nurse practitioners, and nurse leaders, with the tools to recognize, manage, and advocate for these patients more effectively. Our goals for today are straightforward but meaningful. First, we'll focus on early symptoms and signs of ATTR amyloidosis, particularly those that are subtle and often missed. Next, we'll look at current clinical trial data for both ATTR cardiomyopathy and hereditary polyneuropathy, helping us better understand the evolving treatment landscape. And finally, we'll explore actionable nursing strategies. I want to make sure that I mention that these actionable nursing strategies can include those from all walks of nursing care, anywhere from care coordination to patient and family education. This aim here is to improve not only treatment adherence, but quality of life for individuals affected by this disease. Without further ado, I'll look to then request Dr. Felker. Thank you, Doctor.
Thank you so much, and good afternoon. It's a pleasure to be here. So I'm Mike Felker. I'm a heart failure cardiologist at Duke University in Durham, North Carolina, and it's wonderful to be here to talk about such an incredibly important topic that is so impactful for so many of our patients. So I'm going to start with just some broad general thoughts on amyloid, just so everybody is level set. So amyloidosis is really a family of diseases that share a common final pathway of pathophysiology, and that is that they all end up resulting in amyloid fibrils being deposited in tissues and leading to dysfunction and disease. Now, there are many different kinds of amyloidosis, and they're classified based on what kind of proteins end up in these fibrils. The two most common that you're going to see in clinical practice are AL amyloidosis, where the proteins are from immunoglobulins. We're not going to talk about AL amyloidosis hardly at all today. What we are going to talk about and focus on is ATTR, or amyloidosis from deposition of TTR protein in tissue. So what is TTR? Well, TTR, or transthyretin, is a transport protein. It's part of normal physiology. It's made by the liver, circulates in the blood. Its job is to carry vitamin A or retinol as well as thyroid hormone around the body. Circulates in these big clusters called tetramers, which can dissociate into groups of 4 and then break up. But under certain conditions, this TTR protein can get misfolded and then start to elaborate in these long sheets that develop into fibers, which then get deposited in tissues and cause disease. And the two most common tissues that you're going to hear a lot about today are the cardiovascular system, the heart in particular, and the peripheral nervous system. So ATTR amyloidosis is amyloidosis that comes from deposition of TTR protein. Now, in general, we now classify ATTR amyloidosis based on whether the TTR protein that's being deposited is normal, and that's often referred to as wild type, which just means it's a normal TTR protein This tends to be a disease of older people. It used to be often be called senile amyloidosis, although that term is not very much in use anymore. It's actually the most common type of amyloidosis. Primarily causes cardiomyopathy, but it can affect other organs. But an important other cause of TTR amyloid are people who have mutations in the TTR gene that lead to abnormal forms of TTR circulating, and this is often referred to as variant or hereditary ATTR amyloid, and this is an inherited condition. It's autosomal dominant, so it can run in families. There are a whole bunch. There's over 130 different mutations that have been identified, and as I'll talk about, in patients who have variant amyloidosis or hereditary amyloidosis, which mutation you have has a lot of implications for what kind of disease you're going to develop. And really, this slide makes that exact point, that when you look at all the different variations, and this slide includes many different genetic variations in the TTR gene. It also includes wild type. And as you can see, depending on what genetic abnormality you have, or if you don't have a genetic abnormality at all that led to your ATTR amyloid, it can have a big impact on what kind of symptoms you develop. Some forms are primarily neurologic. Some mutations caused a mixed type that has multiple different organ systems impacted. Some are primarily cardiac. One important point I'll make a couple of times is that a key feature of amyloidosis is that there's a different variability in penetrance, so that two people who have exactly the same genetic defect do not have the same illness. One person might be extremely sick, the other person might be asymptomatic. So this is not a disease where whatever genotype you have sort of determines how you're going to do. And that's going to be really important as we talk about how to talk to patients about amyloid and family members. So some of these variants are quite rare. Some are not. The variant that you're most likely to hear the most about in the United States, because it's the most common variant form of amyloidosis in the United States, is V122I. This is a variant that causes both cardiac and neurologic disease, but primarily cardiac. What's notable about this variant is that when you look at self-identified Black patients in the United States, it's really quite common. So 3 to 3.5% of self-identified Black patients carry this mutation. Now, does that mean that 3.5% of Black patients in the United States have amyloidosis? And the answer is no. And the reason is what I mentioned earlier, that this is very variable penetrance. So two people can have the same genetic defect, but very different amounts of disease. And really the best terminology to think of patients who have the genetic defect but do not yet have any evidence of disease is that they're carriers. They might go on to develop disease because we know penetrance is age-related, and amyloidosis is a disease that emerges as patients age. But this V122I phenotype, because it's so common in the United States, is probably the most common one you'll see. And when we look at all the genetic variants in amyloidosis, what we see is that historical migration patterns have a huge impact on what patients are most likely to have what specific mutation. So, for example, V122I is very common in West Africa, and not surprisingly, based on historic migration patterns, it's very common in self-identified Black patients in the United States. There are in other parts of the world, other mutations are much more common. But again, in patients of variant amyloid, knowing what mutation you have is relevant. So one of the key messages for tonight that I'm going to try to get across is that amyloid is a diagnosis you cannot make unless you think about it, because amyloid is a diagnosis that's hidden out there, masquerading and mimicking a bunch of common diseases, and especially common diseases in older people. So I'm going to harp on this idea that you need to have this pattern recognition. If there are certain things you see, they need to make you think about amyloid. So in the heart. Amyloid presents as a restrictive cardiomyopathy usually. It's very, can often be indistinguishable from what you would think of as just garden variety, run-of-the-mill HFpEF, often associated with atrial fibrillation, just like regular old HFpEF, often associated with conduction abnormalities, just like a lot of older people with cardiovascular disease. But amyloid often has effects on the musculoskeletal system, which can often help trigger that memory. The things that I always say you should look out for: bilateral carpal tunnel. If somebody's had carpal tunnel syndrome, especially on both sides, spinal stenosis or back problems, of course, very common. Trigger fingers, if you've seen those are all things that should make you think in a patient with HFpEF, I wonder if this person could have amyloid. In the nervous system, polyneuropathy, of course, extremely common in patients and our diabetic patients. But again, seeing these things together, HFpEF, history of carpal tunnel or lumbar stenosis, polyneuropathy, and then autonomic dysfunction, chronic GI problems, erectile dysfunction, orthostatic hypotension, all these things sort of travel together and should make you think about amyloidosis. And there's several different schema of different things you should look for. There's no one magical sign that you say, aha, if this person has this, I know they probably have amyloidosis. But you should think about this in older patients who have HFpEF, patients who have very thick walls on their echo. So some of these are cardiac. Some of the things I talked about earlier, like intolerance of standard heart failure therapy and hypertensive medications due to hypotension, chronically elevated troponins, bilateral carpal tunnel, unexplained neuropathy, conduction abnormalities, atrial fibrillation, low QRS I'll talk about in just a second. So one of the things I learned in medical school that probably wasn't completely right was that an important thing to look for was low voltage on the ECG. And that's, if you look in textbooks, one of the things you often see as a sign of amyloidosis is low voltage on the ECG. And amyloid does cause low voltage on the ECG, but it's not a particularly sensitive sign. Many patients with amyloid do not have low voltage on their ECG by traditional criteria, and many patients with low voltage on their ECG do not have amyloid. What is, I think, useful is when you see people who on their echo, they have HFpEF, they have very thick walls, you think, oh, that's maybe just from hypertension, and you think that they should probably have LVH on their ECG, but that combination of thick walls but low voltage together can be quite helpful. When patients get global longitudinal strain imaging, one of the things we're increasingly recognize is that the apex of the heart is spared in amyloidosis, especially in late-stage amyloidosis, and that leads to the so-called cherry on top view where you have this red apex and everything else is around it is light-colored. So when you see this apical sparing on echo, it's another sign. Again, none of these are 100%, but collectively and cumulatively, they should be making you think about amyloid. So this is the most important thing I'm going to say during my talk today, which is how to diagnose amyloid. How should you approach it? Because you will never diagnose amyloid unless you think about it. And then once you think about it, you have to know what to do. And so the first thing is the clinical suspicion. The single most important thing I'm going to say is if you suspect amyloid based on clinical features, you cannot tell based on those clinical features if someone might have AL amyloid, which is a hematologic disease because of production of monoclonal immunoglobulins in the bone marrow, or transthyretin amyloidosis, which is what I'm talking about tonight. You can't tell based on physical exam or echo or history. The very first thing you have to do when you want to work up somebody for amyloidosis is you have to test for monoclonal proteins. This is an easy step to skip because it seems complicated and obscure and maybe these would be hard to interpret, but you can't skip this step. So measuring kappa and lambda light chain ratio, measuring immunofixation electrophoresis of serum and urine, those three tests, which are simple serum and urine tests, they have to be sent. And the reason for that is you have to figure out who might have AL amyloidosis. If those are abnormal, that's really a hematologic problem, needs relatively urgent treatment often, and so that's like a definite referral to a hematologist. If those things are normal, then you can move to the next step, which most commonly in the United States is PYP scanning, which many people are now familiar with. It's a nuclear medicine test. It's actually quite a good test. It allows for non-invasive diagnosis of cardiac amyloidosis. It's not a perfect test. There are some ways it can be messed up, but if it's negative, then that makes amyloidosis relatively unlikely. So just a few extra points. A lot of people, when they read these tests for monoclonal proteins, they think about sending an SPEP and UPEP. That's not the right test. It's not as sensitive. So light chains and serum and urine IFE are the tests to screen for AL amyloidosis. And we were talking earlier, the PYP scan, again, can be a good test when it's done properly. There are some places who are not used to doing it. And so if you have equivocal results, don't let that dissuade you, and consider repeat testing or potentially even biopsy. Once you have a diagnosis of likely ATTR amyloid, the next step is to do genetic testing to figure out, does this patient have wild type? So that is, their transthyretin protein is just normal, or do they have a variant? Do they have a hereditary genetic illness? Because as I said at the beginning, that has a lot of implications for what you're going to do. Now, we know amyloidosis can occur with a bunch of other diseases. So just because someone has aortic stenosis, even if they have a low ejection fraction or what seems like hypertrophic cardiomyopathy, don't be so quick if they have some of these other red flags or warning signs to think, well, they must not have amyloidosis, because it can accompany these other illnesses. There's been a lot of interest in how can we screen populations to try to find patients who have amyloid, and the truth is we don't really know at this point how to do this effectively with a high yield. When you screen populations, you find some people who have amyloid, you find some people who have all kinds of other cardiovascular diseases, but really the way we're going to diagnose more people with amyloidosis, are people in this room are going to have to think about it, and when they see a patient who might have amyloid, and instigate the right diagnostic pathway, because we know that the treatments work much better when they're given early, as you're going to hear. And now I'm very happy to turn it over to Kunal, who's going to talk about therapies.
Thank you so much, Dr. Felker. That was great. My name is Kunal Bhatt. As you see there, I'm a heart failure transplant cardiologist at Emory University, and I run the cardiac amyloidosis clinic. And so I am excited to talk to you about the therapeutics. But before we move on to the therapeutics, we'll talk about this case. So we have a 62-year-old woman living with hypertension. She presents to the clinic with worsening leg swelling, fatigue, and exertional dyspnea. She's being evaluated for HFpEF, and she's got a history significant for lumbar stenosis. Her NT-proBNP is elevated at 3,400, and her echo shows that both ventricles are thickened with reduced global longitudinal strain. So questions are, what features in this patient's history raise suspicion for ATTR, and what are the appropriate next steps? Dr. Felker, I'll ask you.
Okay. So this is, of course, a very common scenario where someone comes to your practice or office and they're being evaluated for HFpEF, and they certainly have signs and symptoms suggestive of heart failure. I mean, as I said, whenever I see this medical history of lumbar stenosis or bilateral carpal tunnel, those things always jump out at me. It's a fairly high NT-proBNP level for somebody with HFpEF, which also kind of jumps out at me because we know amyloid is associated with high circulating troponin, but also high natriuretic peptides. Doesn't really say on here, but certainly if I was looking at the echo, I would want to look at the global longitudinal strain and look for signs of apical sparing. And we don't have it on here, but an ECG, it's not perfect, but is often a very helpful test, especially when interpreted in the setting of how much, what their wall thickness is. But
Thank you. Okay, so I'm going to be talking about the therapeutics in this field, and the therapeutics in this field are the reason for so much excitement and probably the reason that we're here talking about this disease, honestly. So when you think about treatment for ATTR, what I like to tell my patients and our fellows is that you've got to think about it in a two-pronged approach. So one arm of treatment is that we've got to treat the heart failure that results from amyloid. And so let's talk about that first. So treatment for amyloid tends to be a little bit different than our traditional therapies for HFrEF. So in HFrEF, I think we all know the 4 pillars of GDMT, and we've memorized them and can be woken up at 3 in the morning and you can spit them out. But in cardiac amyloidosis, the 2 things to remember are that beta blockers, which has been the mainstay of heart failure therapy for 30 years, are actually not thought to be beneficial in cardiac amyloidosis. Similarly, ACEs, ARBs, ARNIs are not thought to be beneficial. So those are 2 big things that you have to remember when you see a patient with cardiac amyloidosis. However, the MRAs like spironolactone, eplerenone, SGLT2s are very useful and are frequently used. And then the other thing that's worth mentioning is that anticoagulation is very important in the setting of AFib. So even if the patient does not have other risk factors, the mere fact that they have cardiac amyloidosis means that they should be anticoagulated. And then, of course, diuretics are the mainstay of therapy. So as we've talked about now, the volume management is the mainstay of therapy. And most of these patients will at some point in time present with some form of volume overload. Oftentimes, these are right-sided heart failure symptoms. And so a lot of peripheral edema, sometimes high JVD, loop diuretics like torsemide and furosemide are a standard of treatment. And then we also use the SGLT2s now much more frequently. The other thoughts that we've already shared are, ACEs, ARBs, and ARNIs and beta blockers are poorly tolerated, and there's a reason for that. So these patients have a restrictive cardiomyopathy, and in restrictive disease, lowering blood pressure, doing afterload reduction does not actually augment cardiac output. It causes hypotension. And so sometimes these drugs can cause profound hypotension. Similarly, in restrictive cardiomyopathy patients, they rely heavily on their heart rate to increase cardiac output when they're doing activities. And so by giving a beta blocker, when we artificially lower their heart rates, they tend to feel terrible. So one of the fun things I get to do is I take patients off beta blockers and ACE inhibitors, and they think I'm fantastic because they feel so much better the next time they see me. And then rounding out digoxin, there's some old data to say that it might bind the amyloid fibrils and cause toxicity. There's been some newer data from the Mayo Clinic with a retrospective review that may not be the case. Similarly, the calcium channel blockers, verapamil and diltiazem, are thought to bind the amyloid fibrils and cause toxicity. So you can use them, but should be careful about toxicity. And then midodrine and droxidopa are used for orthostatic hypotension in those patients who have autonomic dysfunction. Organ transplantation is possible, but rare. So at my institution, we've done about a dozen transplants in the last 5 years for TTR patients. And when we see patients present sort of in an advanced stage, we tend to be very aggressive about organ transplant. And then ICDs are controversial and probably not in the scope of this talk. Now, for the exciting stuff. So on the other arm of treatment, we're looking at strategies to stop the protein production or stop the protein production from depositing into the heart and essentially stopping the disease from getting worse. And so to understand the treatments that we have now, we go back to what Dr. Felker was teaching us about, is that this pathophysiology really is very important in understanding the treatments. So the liver makes majority of TTR. TTR exists in this tetrameric phase where 4 monomers, 4 TTR proteins come together to form its purposeful form. And for reasons that either are age-related or because of a genetic mutation, this tetramer falls apart. And when it falls apart, it forms these monomers, and then these monomers have this odd property that they can misfold and form amyloid fibrils. And then these fibrils are the ones that cause the damage, and they get deposited in the heart and then different places depending on the mutation. So initially, the only thing we had for treatment way back when, 20, 30 years ago, was a liver transplant. And we have come a far way from that. The next phase of treatments that came out that we'll talk about are TTR silencers. The TTR silencers were initially tested in patients with hereditary polyneuropathy and found to be beneficial. And then more recently, there's been a lot of excitement because one of them has been shown to be beneficial in cardiomyopathy patients as well, and we'll talk about that. And then TTR stabilizers have been the mainstay of therapy for a while because tafamidis came out in 2019 and has been the only drug that we've had available for patients with cardiomyopathy for a while. And so talking about TTR stabilizers, what I tell patients when I'm trying to explain what these drugs do is I tell them that this drug class essentially glues this tetramer together and doesn't allow the tetramer to fall apart. And if the tetramer doesn't fall apart, then you don't get the cascade leading to the amyloid fibrils that end up in the heart or the nervous system. And so essentially the TTR stabilizers prevent further progression of disease. And so we've got two TTR stabilizers. And so the first TTR stabilizer that came on the market was tafamidis. This was FDA approved in 2019. The study that showed benefit was the ATTRACT study. And the ATTRACT study looked at 441 patients. They were randomized to tafamidis or placebo. And as you can see there, it took a while because this is a slow progressive disease that at about 18 months, the curves between the placebo arm and tafamidis started to splay. And so it took about 18 months before you could see a benefit of tafamidis. But sure enough, at 30 months, there was a significant benefit when it came to all-cause mortality. And so we know that tafamidis has been shown to have this significant mortality benefit. But some of the secondary endpoints that are worth mentioning are that in this disease, which is very progressive, the 6-minute walk test is progressive, but it's slow. It progresses in a more slower fashion when you look at tafamidis versus the placebo. And similarly, the quality of life scores are also diminished in their decline. The second drug came out back in November of last year, so just very recently. That is acoramidis. Acoramidis was studied in the ATTRibute study. And in this study, they looked at about 600 patients, where 400 were randomized to the drug and 200 to placebo. And again, what's remarkable is that, again, you see the same benefit at 30 months, where there is significant improvement in all-cause mortality or first cardiovascular hospitalization. What was also remarkable about this is that despite this being a very slow progressive disease, you saw the curves splay out at a very early phase. And I think that was a surprise to a lot of the investigators. And so acoramidis has been shown not only to have a significant risk reduction in all-cause mortality, but also in the frequency of all-cause mortality. In addition, there were other things that they looked at, and so there was an increase in the 6-minute walk test. The NT-proBNP was significantly reduced. The serum TTR levels increased significantly. And then, interestingly, the AFib burden in this disease, about 70% of patients will have AFib. And so with this acoramidis study, they showed that the AFib burden was reduced, which is remarkable as well. Finally, we're moving on to silencers. And so silencers are an amazing new therapeutic. And the discovery of the sort of therapeutic class really has changed some of the mRNA therapeutics that are available in many different diseases. And so in this therapeutic. If we look at it, the liver makes the TTR, and reminding us of our high school biology, DNA gets transcribed to mRNA, and then mRNA gets translated to proteins. And so in this, if we are able to bind the mRNA and cause this mRNA to get degraded either by a small interfering RNA or by an antisense oligonucleotide, you end up with no mRNA and hence no protein production. And so in this class of drugs, basically they target the mRNA and make it so that there's no protein that's produced altogether. And so the one drug that we'll be talking about is the vutrisiran. Vutrisiran was studied in the HELIOS-B study where they looked at 655 patients who were randomized to getting vutrisiran versus placebo. And again, amazingly, as you see, at 30 months, there was a split in the curves for all-cause mortality and cardiovascular events. And when they extended this out to 42 months, you can see that that gets even more dramatic and benefit. You can see that there also was a decrease in heart failure visits, cardiovascular hospitalizations, heart failure hospitalizations, as well as mortality, as we talked about. And so one of the questions that a lot of people were curious about was that whether adding vutrisiran to tafamidis or vutrisiran to acoramidis would have benefit. And so this study had 40% of patients were taking tafamidis. And what you see there is that while there was potentially a signal for benefit, really there was not statistically significant. So I think at this point, we don't have data that supports using two of these therapeutics together, at least from clinical trial data. And then again, with HELIOS-B, like the other trials that I've showed you, there was a benefit in the 6-minute walk test as well as the quality of life scores. So really remarkable treatments that we have now options for our patients. The way to think about them is that there's two drug classes. There's the stabilizers, which are both pills. So tafamidis is a pill that you take once daily. Acoramidis is a pill that you take twice daily. They both have been shown benefit in our cardiomyopathy patients. They have not been studied in neuropathy. And the most common side effects that we see are, some very mild diarrhea or abdominal pain in acoramidis. And in tafamidis, really, we don't see a lot of side effects at all. Vutrisiran is a sub-Q injection that's taken every 3 months and needs to be given at an infusion clinic or a cardiology clinic or some medical institution. It has been studied both in neuropathy as well as cardiomyopathy, so it has benefit in both from clinical trial data. And again, the only side effects that we see are maybe injection site irritation. The only difference between these is that because vutrisiran stops production of TTR altogether, and TTR, like Dr. Felker taught us, is a carrier of vitamin A, these patients need supplemental vitamin A. And then this is just a slide showing us that there are a lot of resources, because this is data that I know because I live it every day. But if you don't live this data every day, there's a lot of resources out there for you to use to look up for your patients.
Thank you, everyone. I hope that crash course in amyloidosis you found digestible. I hope my next few slides will be just as digestible as we'll talk about roles related to the nursing involvement in amyloidosis. I want to first and foremost call out that, my particular journey, or within my own journey with ATTR, know that it wasn't always top of mind. But through collaborative learning and ongoing exposure, for me, was patient-to-patient stories. I've seen how critical it is to conduct early recognition and help to support coordinated care truly early. So for me, I'll be focusing on targeted therapies for ATTR-CA and how they translate into the nursing practice. Know that we are oftentimes, we as nurses, the bridge between diagnoses and daily management. So know that whether you're in direct care, patient education, or care coordination, know that we all play a role in helping patients navigate the nuances of therapy, especially when new medications are introduced or even treatment plans shift based on symptoms or access to use. So I first want to dive into a particular patient I'd like for us to consider. This is a woman with a history of hypertension, fatigue, and exertional dyspnea. She was diagnosed with ATTR-CA 2 years ago, and she started on tafamidis, but is now experiencing worsening symptoms. In this particular case, what many of us perhaps see is, oh, the patient's doing okay on therapy, but then showing signs, but not necessarily showing signs related to progression of disease. So here we have a position where she may soon transition to acoramidis or vutrisiran, pending insurance. So this is where we get into some of the nuances related to treatment, and know that as nurses, we are often the ones answering these questions, perhaps related to what does it mean for me as patients. So herein, we want to make sure that we indeed are well positioned to set expectations realistically, support adherence, and ensure that patients like this understand the medication route, side effects, and even what next steps could occur. So when we speak about setting expectations, no, it's important to really call out the gaps related to what we know and what we don't know about this rare disease. Setting expectations early, first and foremost, is one of the most powerful things that we can do as nurses when working with our patients affected by this disease. The most targeted therapies for ATTR-CA either can stabilize or silence, as mentioned by Dr. Bond, the TTR protein. Know that this is indeed critical to explain that they are not curative. TTR stabilizers like tafamidis are oral medications, as mentioned, while silencers such as vutrisiran or patisiran require infusion or injection. They all require daily vitamin A, as mentioned. Daily vitamin A supplementation, which can often be overlooked. But know that we as nurses need to be clear. We want to make sure that these therapies we ensure that we educate to the point that these therapies aim to slow progression, not reverse damage. And additional treatments are often needed to address symptoms. This is where our nursing guidance, especially during medication counseling, follow-ups, and teaching moments, become very essential. This next slide, as mentioned, here just share some good news. Again, the mortality outcomes for ATTR-CA have indeed improved significantly, thanks to early diagnosis and availability of therapies. More patients are being referred sooner, particularly after advanced cardiac imaging. This reflects a shift towards earlier recognition, a trend that we nurses can indeed help and make a strong influence on and accelerate through thorough assessments and persistent advocacy. However, I want to make mention that disparities still indeed exist, especially with the V122I variant, which is more common among Black individuals, or particularly individuals of African descent. These patients still experience worse outcomes, and that's something that we indeed need to pay attention to in both research and in practice. Now, I want to make mention that we indeed lean into biomarkers. Know that specifically highly sensitive troponin and NT-proBNP, which are increasingly used to monitor disease severity. Now, in this particular slide shares that one large cohort includes patients with elevated HSCTNL and NT-proBNP had significantly poorer survival. However, there is no universal consensus on a standard monitoring strategy as of yet. So what does that mean for us? As nurses, we often support the implementation of these monitoring plans and know that explaining their significance to patients, identifying trends, and flagging or acknowledging some of those red flags that you have learned today. Know that even in practice, while practice patterns vary, we indeed can help to ensure consistency in what patients hear and understand. This particular slide related to early TTR response to acoramidis may predict survival really calls out that this study shows something quite exciting. Early increases in serum TTR with acoramidis may predict better survival outcomes. It underscores the importance of closely monitoring early responses to therapy, not just from a pharmacological standpoint, but from a nursing perspective as well. We as nurses should be advocating for early lab work, early follow-up, and patient adherence checks. Our role is not to simply administer care, to ensure that the right care continues and that patients stay informed, engaged, and supported every step of the way. This next slide I'd like to call out simply by asking the question, how old is too old to benefit from treatment? Know that you may oftentimes hear in your practice, is my patient too old for treatments such as these? The answer increasingly is no. Know that especially with data showing on this slide, we here can look to support patients living longer than those who are not treated. Know that age alone should not exclude someone from therapy. So what matters more so is functional status, goals of care, and comorbidity management. This slide particularly calls out a decision tree related to treatment. We now have, as mentioned by Dr. Bott and Dr. Felker, now have several targeted treatment options to include tafamidis, acoramidis, and vutrisiran, and more are in development. What is important for us nurses to really stay close to is to really understand the various routes of these medications, dosing schedules, and clinical indications. As mentioned, for instance, tafamidis is a daily oral stabilizer, while vutrisiran is a subcutaneous silencer given every 3 months. Understanding these distinctions is vital, not just for prescribing providers, but also for us too. We know that we are oftentimes the ones counseling on administration, managing adherence issues, and helping troubleshoot side effects. As I mentioned side effects, I do want to call out that GI side effects can be found. Know that GI involvement in ATTR can be indeed challenging and sometimes debilitating for patients related to participating in normal activities of daily living or even participating in work. Know that unfortunately, we do not have evidence that currently target therapies to improve GI symptoms, but know that there is supportive management and symptom tracking, and this is essential to communicate to the patient. Symptoms such as diarrhea, weight loss, early satiety, these all need to be actively addressed with multidisciplinary input. So we as nurses, knowing that we are advocates in these spaces, can help to lean into what nutritional consultants we have at within our networks in order to support these patients. Also to support any perhaps GI workups that can be found in place in the patient's care plan, and palliative support as a part of routine care. Again, this is not found necessarily in the late stages of the disease process. Frailty is very important, and know that it is a powerful predictor for poor outcomes in patients affected by ATTR-CA. Again, it is not about age, it's about physical reserve, comorbidities, and resilience. Know that risk factors like being female, having diabetes, or carrying the particular variant called V142I increase vulnerability. So we as nurses are uniquely positioned to assess frailty even before formal tools are used in your practice. What can we as nurses observe? Some low-hanging fruit include declining ADLs, repeated falls, fatigue. Again, these should look to inform our care plans and escalate conversations about supportive needs early on. Now, I mentioned palliative care. We want to make sure that we can look to normalize palliative care in ATTR-CA, not just for end of life, but for symptom control, decision-making, and quality of life at any stage. Know that you're oftentimes in your practice asked, what will this medication do for me? Know that, again, we're thinking about always looking to open doors for honest, supportive conversations with patients affected by ATTR-CA. We'll soon, very shortly here, begin a panel discussion and open up for questioning. I'd like to just quickly bring up just a few mentions related to the American Heart Association's framework for approaching patients with suspected or confirmed inherited cardiovascular disease that includes ATTR-CA. Know that while this particular document is physician-focused, know that nurses are integral in putting this particular framework into action. So this will be available to you via the slide deck. I want to take just a few moments, as I know we are, time is of the essence as we get to the end of our presentation. I do want to take a moment to call out that we cannot talk enough about ATTR without acknowledging disparities in research participation. Know that this is particularly prevalent among individuals of African descent, particularly Black Americans, who are disproportionately, as mentioned by Dr. Felker, affected by the V122I variant. Know that this particular slide highlights what concerns myself and colleagues have found through our research related to what barriers exist to research participation, which includes health information privacy concerns, precision medicine addressing health disparities, also related to physician willingness to participate in or even conduct precision medicine research that helps to lead into more realizations about this disease. Another concern includes understanding target audiences among Black American communities for promoting precision medicine research. And then indeed, we know that there are language barriers that affect individuals of all walks of life, all ethnicities, as it relates to participation in precision medicine research and research participation for medications. What I'd like to truly, again, really highlight is not only did myself and colleagues with the National Black Nurses Association able to identify existing concerns, we were able to, through semi-structured interviews, call out newly emerging themes. This is related to authenticity in outreach. It also speaks to patient empowerment and activation. What patients are looking for when you're looking to ask them to participate in research is authenticity, as well as a true buy-in related to empowerment that the patient has should they participate. They want to be seen as partners, not necessarily participants. There's also research retention. Again, that buy-in is important not just at the initial phase or the recruitment phase, but also throughout the research journey. Accountability for responsible research conduct has always been the mainstay. And know that this is very important to individuals of African descent should they be asked to participate or even have interest in participating. Know that informed consent is very important in understanding the ins and outs of the verbiage used, as well as physical location. Know that we still have amyloidosis care center deserts. We still have areas where patients do not have access to some of your major care centers to support individuals that are affected by this disease. Lastly, communication with routine healthcare providers about research participation is important and important to keep at the top of mind related to this disease process and what research participation exists. And while we call this out, know that not only are we looking to lean into how to support patients who are affected by this disease, we're oftentimes looking to make sure that we collaborate with family members as well, whether they're affected by age-related disease of ATTR wild type, or we have ATTR variants, which either disease can affect individuals of African descent and others, and again, present with cardiovascular manifestations. Know that again, in the essence of time, I want to make sure that I lean into 3 essential components of multidisciplinary care with patients with amyloidosis. Know that high quality care for patients with amyloidosis, particularly related to ATTR, require more than just one specialty. Not only are us nurses and providers, to include nurse practitioners and physicians, important to include, but know that this slide highlights 3 essential components related to shared decision-making, streamlined communication, and care continuity. Nurses are central to each of these. Know that we're often the ones following through on what is discussed in the exam room, whether that's coordinating tests, clarifying treatment expectations, or connecting patients to community resources. Know that shared decision-making doesn't just happen in a vacuum, but it happens when patients are informed, heard, and supported. And this is where we come in. We are there to clarify options, reinforce goals, and advocate for what matters most to each individual patient and their families. So no single provider has the whole picture. Together, however, we can create a care plan that is not just clinically appropriate, but also meaningful to the patient. And this is indeed to ensure continual engagement. So know that you don't have to, as nurses, do this alone. Neither do your patients. There are fantastic amyloidosis centers that exist across our country, and academic medical centers that oftentimes have specialized teams to support that multidisciplinary approach for care. It is our job to, at least for start, and for you to guide patients to choose what resources work best for them, to include a proper amyloidosis cardiac center. Know that especially if their local cardiac clinic lacks experience with ATTR, know that whether it's finding support groups, clinical trials, or second opinions, nurses can indeed be navigators for patients such as these. So this particular slide shares where you can look to find amyloidosis care centers or particularly treatment centers around our country. This next slide really is the heart of today's message. Again, nurses are not peripheral to the care of patients with ATTR. We are indeed central. Whether it's assessing patients for red flags, coordinating particularly advanced imaging, or genetic testing, know that managing medications or educating families is indeed what we do in our daily work. And this ensures care plans are actionable, accessible, and consistent. Know that our goal with ATTR, with patients who are affected by this disease, as well as their families, know that our goal goes a bit further than our typical patients we see every day. Know that we must liaise with cardiologists, neurologists, palliative care teams, and community resources in order to support patients such as these. We keep patients from falling through the cracks by following up on missed appointments, checking labs, and tracking symptom changes. We also educate and support other healthcare providers, and this is what indeed we are asking you to leave today doing in your practice with your networks, especially in settings where ATTR is not yet well understood. So in short, know that nurses, we are uniquely positioned to bridge the clinical, emotional, and logistical aspects of living with this disease. We are care navigators, educators, advocates, and most importantly, the most trusted nursing profession. So you just digested a lot of information over the last 55 minutes. Know that I'd just like to take a moment to recap. ATTR can be missed, but nurses can help to spot it sooner. Targeted therapies improve outcomes, and patient education is key to success. Frailty, GI issues, and disparities must be part of our clinical awareness, and disciplinary care grounded in trust, advocacy, and education is essential. Thank you so much. I'd like to entertain a few questions here for Dr. Bott and Dr. Felker. I have my first question. If you have a patient who has already paid for tafamidis for the year and they want to start vutrisiran, would you keep both therapies until the end of the year and then drop the tafamidis at year's end?
Yeah, so I can take this. There is no harm in combination therapy. In fact, there was a lot of excitement early on that combination therapy would help patients more than single therapy. So for this patient, I would definitely recommend that they continue the tafamidis until the end of the year, and then depending on what they want, continue one or the other, depending on their preference.
Excellent, thank you. Next question, we have a question related to a young patient with high clinical suspicion but negative testing. How soon would you retest, or would you retest?
Maybe I'll take that one. So, some of it depends on what testing we're talking about. As was mentioned, PYP scanning is a good test, but it's not perfect. It's more often, if it's not done right, it's more often saying someone has amyloidosis who doesn't than vice versa. But it's not a perfect test. So I think in the setting of a very high clinical suspicion, I don't think you should be dissuaded by a negative PYP test, but the right next step in that person is probably biopsy and get tissue, which if they have cardiac amyloidosis, that's in a myocardial biopsy, which is a cath lab procedure, which used to be something we did all the time, but now with PYP scanning, we are making the diagnosis non-invasively much more often.
Thank you, Dr. Velker. Last question from our virtual participants includes, the question involves sharing that the patient is indeed doing well. The NYHA2 proBNP is stable, no recent hospitalizations. But carpal tunnel is coming back and the septum went from 13 to 15 millimeters. Would you change the treatment agent, or would you use acoramidis or vutrisiran?
Yeah, so I can take this too. The first question would be, if there's any other reason for why the septum is increasing, like concomitant hypertension, which we see a lot of. These patients are generally in their 70s and they have other comorbid conditions like kidney disease and hypertension. And so it's not necessary that amyloid may be the only reason for them to have LVH. Yeah, if the blood pressure is normal and you truly think that the disease is progressing, the return of the carpal tunnel, I have to say, is that there's no clinical trial data to show that these drugs actually help with carpal tunnel. And so carpal tunnel needs to be put on the side, and there may be data that comes out in the future. But if there's truly thought that the cardiomyopathy is progressing, then yes, the two choices are either you switch to acoramidis or you switch to vutrisiran. And again, the question would be, what would the patient choose? Would they want to come every 3 months and get an injection in the hospital setting, or would they take a pill at home twice a day?
Excellent. Thank you, Dr. Bott. I'd love to hear from anyone in the room. We've got about a minute left. We have microphones available. Question.
Now, cardiac MRI, if you jump from PYP to biopsy, at my center, we do a lot of cardiac MRI.
Yeah, so cardiac MRI is a good test for amyloidosis, but it's not definitive. So I'm interested in what you think too. In general, we wouldn't make a definitive diagnosis. It would certainly raise our suspicion, but we would make a definitive diagnosis and start treatment based on a cardiac MRI finding.
Yeah, I think in clinical practice, this comes up all the time. So you have a high clinical suspicion, but your testing is negative. And then you're thinking, what's the next step? Do you jump straight to biopsy in this 80-year-old, or do you do something intermediate? The problem with the MRI is it's not going to tell you what kind of amyloid. And the MRI is not going to be able to, you will not be able to use the MRI to convince the insurance to pay. So unfortunately, you're back to either biopsying them or repeating the PYP, which are the only two modalities with which you can get the drug paid for. So depends on the patient. If the patient's willing to go for biopsy, which oftentimes I talk about, then I'll just go straight to biopsy, because the MRI just prolongs the problem. It kicks the can down the road. At the end of the day, you're still stuck with the same problem.
Great. Thank you both. Thank you, Dr. Felker and Dr. Bott. Thank you so much for your participation, and have a great evening.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Alnylam Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/HXH860.